Okay, so last I left off, we had just got into the urinary tract infections. We talked about meningitis and the various bugs that cause meningitis. We talked about the various bugs that cause pneumonia and the various diarrheas. Now, urinary tract infections, first of all, it's really important to identify it correctly, right? Don't confuse it with what could be either bladder cancer or any other kind of inflammation, either due to renal difficulties, right? Maybe nephritis, nephrotic syndrome, something like that. So people with urinary tract infections will present with dysuria, frequency, urgency, suprapubic pain, and you will see white blood cells, but not white blood cell casts. Remember, white blood cell casts are the things that are related to renal problems, right? So you'll see actual white blood cells in the urine, and finding white blood cells in the urine is pretty much a good hint at urinary tract infections. Primarily caused by the ascension of microbes from the urethra to the bladder. Ascension to the kidneys can result in pyelonephritis, which presents with fever, chills, flank pain because of the kidneys, right? Costovertebral angle tenderness, again because of the kidneys, hematuria, and now you see white blood cell casts, right? So until you don't see white blood cell casts, it hasn't become pyelonephritis, nor has it become any kind of renal issue. 10 times more common in women because women have shorter urethras, right? Shorter urethras colonized by fecal flora. So it's very possible for a woman to get a urinary tract infection as opposed to a male. Risk factors include obstructions like kidney stones or an enlarged prostate in a male, kidney surgery, catheterization, congenital genitourinary malformations. That can include a bunch of stuff you'll see in renal. One they put here is a vesicoureteral reflux, where the urine is kind of going back from the bladder up the ureters. Diabetes, obviously, because the high sugar creates a good environment for the bacteria. And pregnancy, right? Pregnancy is definitely one of the things too. Now, many things can cause UTIs, but the number one cause of UTI is E. coli, right? E. coli is the leading cause of UTIs. Colonies show strong pink lactose fermentation on McConkey agar, right? And that's one of the hints they would have to give you. So if you get a question about a UTI and not much information is given at all, then you have to go by what is the most possible answer choice, and you would pick E. coli. Right? If they start describing the bacteria to you, right, then you should be able to pick the bacteria based off the description. Right? When we did Staphylococcus saprophyticus, for example, right, her navel was hidden, so Staph saprophyticus was novobiocin resistant, right? Novobiocin resistant, whereas Staph epidermidis was a plumber in the sketchy microimage, and his belly button was showing, the navel was showing, so he was novobiocin sensitive. Right, but Staph saprophyticus is novobiocin resistant. That might be something that's given in the question. Staph saprophyticus is the second leading cause of UTIs. And then Klebsiella pneumoniae is actually the third leading cause of UTIs. Right? So if you get a question where they're describing something that looks like Klebsiella and it's not a pneumonia question, don't be surprised. Right? Many people do not associate Klebsiella pneumoniae with UTIs. They generally just think of it as a pneumonia thing, but actually the sketchy microimage of Klebsiella also had serratia in it, and a third one, and all three of them were also related to nosocomial UTIs as well. There was a urine bag in that image of the patient at the hospital, right? And Klebsiella makes large mucoid capsules, right, with the viscous colonies. So they'll have to describe something that doesn't exactly set correctly with E. coli or Staph saprophyticus. Serratia, remember, is the thing that causes the red staining around the toilet that hasn't been used for a very long time, an unclean toilet, because they are actually the one that produce a red pigment. Often nosocomial and drug resistant. Most nosocomial guys are drug resistant. Right? Enterococcus is also nosocomial and drug resistant and can cause UTIs. Right? Enterococcus, when we did it, the sketchy microimage also spoke about the bile tree being infected. So again, this bug can come with multiple things, right? A patient with a UTI might actually have symptoms of other things as well, just to throw you off, but also to actually help you point to the correct bug. Proteus mirabilis is the guy that causes your struvite stones, right? This is your calcium phosphate magnesium stones that look like a coffin lid. Right, so that's like the little details you have to know when solving such questions like that. And it's urease positive, so that's another thing that would be there. So is Staph saprophyticus, though. Staph saprophyticus is also urease positive. Last one that can cause UTIs is your Pseudomonas aeruginosa, where they would either mention the blue-green pigments, the fruity color, fruity odor, or mention other things like what antibiotics are working against it, how the patient might have gotten the UTI, etc., etc. Now, when you do rotations in in USA, in American hospitals, you'll see, and even in other country hospitals, you'll see diagnostic markers for patients who are coming in to get tested for UTIs, right? Leukocyte esterase, nitrite, and urease. Now, leukocyte esterase positivity simply tells you there is white blood cell activity, which pretty much almost entirely confirms the fact that there is a UTI, right? Because you're finding white blood cells in the urine. The nitrite test is a reduction of urinary nitrates by gram-negative bacterial species. So a positive nitrite test pretty much just confirms it's E. coli. Like literally almost confirms it's E. coli, because the other, like Pseudomonas aeruginosa is not that high. Not high yield. It's not the number one cause of UTIs, right? It's more likely it's E. coli. If a patient comes in and they have a positive nitrite test, it's probably E. coli, because the nitrite test tells you it's going to be gram-negative, and the most likely gram-negative thing that can cause a UTI is E. coli. You wouldn't pick the Pseudomonas aeruginosa unless there's something else given in the question that really points at Pseudomonas. Now, the positive urease test, everything that's urease positive would give this to you, right? So that includes Staph saprophyticus, Proteus mirabilis, and these two guys as well. The same guy that's laying in the hospital in sketchy microimage for Klebsiella and Serratia, he's also holding the urease spray, and he's spraying it at these guys because he's trying to save himself from all these bugs that are resistant to all the antibiotics he's on. Right, so urease positivity usually is going to be most significant for Proteus mirabilis. Right, they'll tell you it's urease positive because they're trying to hit you at this. And here is a little question from UWorld that kind of utilizes this kind of lab work. So it says a 64-year-old man came to the office due to 2 days of dysuria, urinary frequency, and urgency. So you see how that perfectly fits the presentation of what a patient with urinary tract infections would present with, right? He recently underwent a cystoscopy for the evaluation of hematuria. So he underwent a genitourinary procedure, right? He underwent a genitourinary procedure, and he also has hematuria, so he already has some kind of renal issue going on. The patient has a history of hypertension, type 2 DM, and smokes 30 pack years, right? 30 pack years of smoking. His temperature is 100.8 F Fahrenheit, and on exam there is suprapubic tenderness on deep palpation, but no costovertebral angle tenderness. So that kind of tells you basically that he has the suprapubic pain, so that means he has a UTI, but he doesn't have the costovertebral angle tenderness, so he doesn't have pyelonephritis yet. Right? But he did have hematuria already. Urine analysis findings are as follows. Leukocyte esterase positive, so yes, there's white blood cell activity. Nitrites negative, so that means whatever is causing the issue is not gram-negative. Bacteria, many, so it's a gram-positive bacteria, okay. White blood cells, 20 to 30, red blood cells, a lot. Midstream urine culture grows gram-positive cocci in chains with growth of more than 100K colony-forming units per milliliter. The organism responsible for this condition is most likely to demonstrate what else? Right, so what gram-positive bacteria could be causing it? And the answer was gamma hemolysis on blood agar. Right? He recently underwent a genitourinary procedure and now has a UTI, and it's growing really, really well. It's super strong. So it is most likely Enterococcus. Right? Not Staph saprophyticus, not Klebsiella pneumoniae, not any of these other guys. Right? Staph saprophyticus is gram-positive also, but they described cocci that are growing in chains. Right, now if we go back real quick just to talk about Enterococcus, because that is a pretty high yield and strong bug. Right, so this is the California caucus. A caucus is a real thing, especially in politics. So you can definitely Google that. Well, actually, let me actually look it up too, because I forgot how I would define what a caucus is. Caucus. So, yeah, it's just a meeting. Okay. Right. So, in some U.S. states, a meeting at which local members of political party register their preference among candidates. Right. So this is literally named the California Caucus because that was an actual thing that happened in history. Right. And we've already done this image already. We've already done gram-positive way in the beginning when we started the microbiology section. We see how there's this banner they're holding in the back, right? U, heart, trees. Urinary tract, heart, biliary tree. Everything gets infected. And the book tells you that this can cause UTIs, right? Can cause UTI, biliary tract infection, or endocarditis following a GI or GU procedure. Right, so gastrointestinal or genitourinary procedure. So anytime you have a patient who underwent any of those things and then came back with one of these three issues, urinary, cardiac, or biliary tree, then that's a giveaway for Enterococcus, right? And that's basically how you would tackle such a question. Now, if you didn't know how Enterococcus looks, or if you didn't know the fact that Enterococcus causes UTIs after a GU procedure, then there really wouldn't be a way for you to answer this question correctly, and you'd have to guess between Enterococcus or Staph saprophyticus, at which point you'd most likely pick Staph saprophyticus because you know it's the number 2 cause of UTIs. But it's the number 2 cause of UTIs mostly in sexually active women. Don't forget that either, right? Remember the image for Staph saprophyticus by Sketchy Micro is a woman, right? It's not going to cause UTIs in men. I mean, it can, but it's not what it's known for, right? But Enterococcus is very strong. Usually questions about Enterococcus will involve either gender, right? But they'll try to give it for a male. They'll try to pick a male as a patient, especially in step 1, right? So a male coming in, because a male wouldn't really get Staph saprophyticus. A male could get UTI from E. coli, right? But if it's not nitrate positive, that means it's not going to be gram negative, so it's not E. coli. Right? So it's really important to be able to understand what a diagnostic marker is telling you. Now, vaginal infections, right? So I have the table right here from UWorld as well, and I have some other images that are part of the first aid to begin with. So common vaginal infections, right? We have bacterial vaginosis, right? This is the only one that's a vaginosis. The only one that's a vaginosis. And then you have Trichomonas vaginitis and Candida vulvovaginitis. Right, but bacterial vaginosis, this is the one that has no inflammation at all. That's why it's not a itis, it's just a vaginosis. Thin white discharge with fishy odor. Right, fishy odor. This is the one that has the positive potassium hydroxide. This was your Gardnerella vaginalis. Right, Gardnerella vaginalis. And Sketchy Micro had the image of a garden, right, where the plants look like a vagina and they were eating all the fish, hence the fishy odor. And there was a detective there to find out where all the fish are going, and he was searching for clues, hence the clue cells, right? And this is also going to have a pH of more than 4.5 because the plants were all priced at 450 or more. So very easy to remember. In that same image, you had a train station for metronidazole. Metronidazole or clindamycin are both fair treatment for this one. And remember that this is not really going to have a clear gram color. Right, it could be gram positive or gram negative. It's gram variable. It's not very well stained by gram. Right, so it doesn't have a good gram staining. Then you have Trichomonas vaginitis. Now Trichomonas, right? Trichomonas vaginitis is the one that has the strawberry cervix, right? Foul smelling discharge. It's a motile trichomonad, right? So image B is showing you that motile trichomonad, and you have to treat the partner as well. You have to treat both people, right? Because this is a motile guy. It's going to go from one to the other. It's going to infect both partners. And if you don't treat both partners, if you only treat one partner, then when the two people have sex again, it'll reinfect the partner you treated, right? So you have to treat both partners once again with metronidazole, right? Candida is the only time treatment changes, and it just becomes any azole, right, which is obvious for fungal infections like that. So Candida vulvovaginitis, thick white cottage cheese discharge, right, and they're showing you that here in image C, really, really thick discharge as opposed to really watery discharge in the fishy odor vaginosis, right? Very thin white discharge, whereas thick white cottage cheese discharge. Very obvious difference between the two. It's something you can see in the hospital for sure. It's something that can be described in question, right? And lab findings, of course, since it's fungal, you'll have pseudohyphae. Pseudohyphae are something Candida is really well known for, and that's really all there is. It's a super easy differential between the three. There's like literally no reason to confuse either three of them. With a little good practice, you can definitely memorize it, right? pH is slightly normal with Candida, right? So the reason this works out is because it's a fungus. It's not really going to go change the pH as opposed to the bacteria guys might, right? And also on top of that, this kind of wants things to be normal. It's just trying to live there, not change the habitat, all right? So the reason Candida grows in a vaginal infection is because it likes the habitat, so it's not changing it. So it's not going to change the pH either, right? Whereas these two guys are just growing because there's an infection and they're causing issues, all right? Bacterial vaginosis. Remember, Gardnerella vaginalis does not cause inflammation, right? But Trichomonas and Candida do cause inflammation. And that's really all there was for that. So very, very good little differential stuff. Now, Torches infections. Definitely a high-yield thing. Very common. You see infections about Torches diseases all the time. You'll get questions where a patient's family might have come from like a third world country or something where vaccinations are not very common, or getting these infections is more common than it is in America, and they just immigrated into America and maybe they have some issue. So let's take a look at them. Microbes that may pass from the mother to the fetus, right? In America, we do our best to make sure these microbes don't pass from the mother to the fetus. We check the mother. If she has these infections, we give the fetus and the mother everything we can to make sure there isn't vertical transmission. So chances are oftentimes these babies are born elsewhere and then they just came into America. For step 1 questions, transmission is transplacental in most cases or via delivery, especially HSV2. Non-specific signs common to many Torches infections include hepatosplenomegaly, jaundice, thrombocytopenia, and growth retardation. Right? These are non-specific signs to pretty much all of these. So if you start seeing hepatosplenomegaly and jaundice in a newborn, start thinking a Torches infection might be involved. Other important infectious agents include Strep A. galactiae, E. coli, and Listeria, all causes of meningitis in neonates, right? And we give penicillin, right? Perinatal penicillin to a mother who might have Strep A. galactiae. We have to give penicillin or ampicillin to the baby who has Listeria. And then for E. coli, you just have to deal with it the same kind of way as well, right? Take care of it. Because remember, the thing that causes it is, I think it was the K capsule, causes the meningitis, so it's really just treating the E. coli in the baby. Parvovirus B19 causes hydrops fetalis, right? That's your virus right there. That's just really bad. So there's nothing to be discussed there. All right. So first guy, Toxoplasma gondii, right? So there's they have this listed out in the order of Torches, TRCHS. So Toxoplasma gondii. Cat feces or ingestion of undercooked meats, more than likely the ingestion of undercooked meat, because no one's going to be eating cat feces or smelling it or anything like that. And pregnant mothers are not supposed to be cleaning cat feces. So if they did, then it's the cat feces. Maternal manifestation, usually asymptomatic. They might have some lymphadenopathy. But the neonate is going to have your classic triad of things that were explained in the sketchy microimage, with the cat wearing the glasses, the big turban, and the other cat who had a milk being dripped onto the head, right? So chorioretinitis, hydrocephalus, so a really big head, right? And intracranial calcifications, plus or minus a blueberry muffin rash, right? Blueberry muffin rash, which is more likely to be seen with rubella. Alright, so they have the blueberry muffin rash here too for rubella. That's the next side. Rubella is transmitted through respiratory droplets, right? Rubella is your German measles, and for that picture, which we just did over the last few days, you had your German prince little boy sitting there with two adults fanning the kid, and the fan had respiratory droplets coming off of it. It had droplets coming off of it, which you're supposed to think of respiratory droplets from. The adults had issues. They were on the ground on their knee, so they had polyarthritis, polyarthralgia. You're going to see that in the mother, right? The kid himself, he was okay for the most part, but there was a wall that had paintings on it, right? It was a baby painting where the baby had its eyes closed for cataracts, it had his ears covered for congenital deafness, and the wall was named something related to PDA. I think it was like patent ductus arteriosus. Oh, patent. I can't remember what the ductus aqueductus. I think they called it patent ductus aqueductus for the name of the wall or something like that. But it was supposed to remind you of a PDA. You get a congenital heart disease, you get the PDA in these patients. And the reason the PDA happens is because rubella kind of slows down muscle development. So if you don't develop the heart muscle correctly at that time, it stays open and you get your patent ductus arteriosus. And the blueberry muffin rash. That's more commonly seen with rubella than toxoplasma, so it'll be the same pictures, same rash, etc. Right? German measles. And rubella was one of your toga viruses. Right? So that's also important to remember. Cytomegalovirus, sexual contact or organ transplant, it's actually pretty common with both of them. And cytomegalovirus SIGHT, SIGHT, so it's HHV5. It's one of your herpes viruses, right? In the maternal manifestation, in the mother, there usually won't be anything. At the very least, you might notice some level of mono, but not really. The mother's going to be okay, right? Especially if the mother is immunocompetent. But the baby is the one that's going to have all the manifestations of cytomegalovirus. So the baby's going to have hearing loss, seizures, petechial rash. We see again blueberry muffin rash, but it's pretty irrelevant. It's really just a rubella thing. Chorioretinitis and periventricular calcifications, right, which you can see in C. Periventricular calcification. The cataracts in a baby, right, just going to be something like that, right? This is when you basically notice that the baby's not tracking the eye very well, not really smiling, doesn't have a social smile, etc., etc. HIV is a tortuous infection as well. Sexual contact or needle stick is how it's usually transmitted, and then the mother can transmit it to the baby as well. But if the mother gets treatment, then you can significantly reduce the chances of transmitting it to the baby. If a baby is born with HIV, the baby will get recurrent infections and chronic diarrhea and most likely die really, really young. The other H is your HSV2. Right, so torches. Torches is supposed to remind you of the herpes as well because the HE. Right, so you see after the H there's an HE. This E is actually significant. So is the O. The O is for toxo, right? So toxoplasma. H is for HIV, but HE is for the herpes. So herpes HSV2. Skin or mucous membrane contact is how you usually do this. HSV2 is also sexually transmitted. That's what the skin or mucous membrane contact is all about. So HSV2 gets transmitted between one patient to another, and the mother can have herpetic lesions, right? Herpetic, weight low on the finger, stuff like that. But generally speaking, the mother's probably just going to be asymptomatic, especially if she's immunocompetent, and it'll just be a latent infection in the mother. But in the baby, it can cause the same herpetic lesions and meningoencephalitis. So that's pretty bad. Last one here is syphilis. Right? Syphilis is another one that's transmitted through sexual contact. It causes a chancre, disseminated rash, right? Depending on what level of syphilis, if it's tertiary syphilis, it can even cause CNS issues. That's what's going to happen to the mother. Neonatal infection was also described in the same picture with syphilis, which was a very complex picture. But it can result in stillbirth and hydros fetalis. The baby can just literally be born dead. One of the little things we saw were the notched teeth. That picture was given when they talk about syphilis in microbiology. And cranial nerve 8 deafness. Right? Those two things are usually given to really help you pick out the fact that it's syphilis. Right, so that's your torches infections. Red rashes of childhood. Now, the rashes of childhood, this is pretty irrelevant for the most part. It's not really going to help you much with the test. Right? Everyone pretty much knows the slap cheek rash. This one is easy. The slap cheek rash on the face for parvovirus B19. And we already talked a lot about rubella versus rubeola, right? Rubella, which is your German measles, versus the actual measles, which is rubiola, right? So measles is a paramyxovirus, whereas German measles or rubella is your toga virus. The issue between the rashes of these two was that in measles, it's a confluent rash beginning at the head, moving down, preceded by cough, cries, and conjunctivitis, and complex spots inside the mouth. But a confluent rash, right? Compare that to rubella, where you have pink macules and papules beginning at the head and moving down, and they remain discrete, fine desquamating truncal rash, post-auricular lymphadenopathy. You see post-auricular lymphadenopathy in both, but it's really a rubella thing. And in measles, the rash is really, really dense. There's no white space. It's just red dots nonstop. Really, really dense confluent rash. Whereas in rubella, the rash is pretty well spread out. Not that many red dots. Alright, so the rest of them, I mean, you could look at them, but it's not really that significant. Neonatal conjunctivitis. We talked about conjunctivitis from a lot of things that can lead to conjunctivitis in a neonate. But oftentimes, when you do get a question about neonatal conjunctivitis, it's really easy to pick what caused it. The only confusion comes between gonorrhea versus chlamydia, and we talked about these two guys when we talked about them in our earlier lectures. Right? Gonorrhea, remember when we did the gram-negative bacteria and we looked at gonorrhea, this was coming off of the fact that the mother covered the baby's eyes really quickly because someone was dying, right? So it occurs really early, so you can see that, right? 2 to 5 days. Whereas chlamydia was very slow, so after 5 days, it can be even after 2 weeks. The other thing with gonorrhea was that the discharge was really, really, how do we call it? Like, it was pretty, let me see. Here they're saying chlamydia has a thick mucopurulent discharge, and gonorrhea has a profuse purulent discharge, right? So that's what it was too. In gonorrhea, remember, the discharge was being displayed by the candle chandelier, right? There was a chandelier that looked like your uterus for the most part, with the fallopian tubes, and there were candles, and the wax that was coming off the candles was supposed to depict the gonorrhea discharge. And the same discharge for also in the eyes. It's going to be extremely thick discharge in gonorrhea. The chlamydia one is mucopurulent. It's more watery of a discharge than the gonorrhea. Right, so not the best differences between the two. There's a lot of overlap, but you have to do your best to pick what it could possibly be. Right? There will be things given in a question to help you pick between gonorrhea or chlamydia. Right? Chlamydia is the most common etiology of neonatal conjunctivitis. Chemical, 1 to 2 days, right? Non-purulent water discharge, irritation from some kind of antibiotic ointment. HSV can be days to 6 weeks. It can this one is the one that can take up to the longest amount of time to show up. Conjunctival injection, non-purulent discharge because it's not bacterial. Keratitis, vesicular skin lesions, right, because of the HSV itself, and disseminated infection, again, because of the HSV itself. Sexually transmitted infections. Now, with sexually transmitted infections, the thing that matters the most is if there are painful lesions or not, right? That's what's going to be given to you in a question. If there's a painful lesion or not, that really helps you knock out a lot of answer choices. AIDS is a sexually transmitted infection as well. Clinical features are opportunistic infections, Kaposi sarcoma, and lymphoma. Pretty straightforward. Chancroid from syphilis, right? Chancroid is a thing you get from syphilis. It's painful, right? Not from syphilis. What am I saying? Chancroid you get from Haemophilus ducreyi, right? And ducreyi is painful. You're gonna always remember ducreyi as do cry. This is the one that almost everyone remembers. No one ever really tends to forget. So if you ever ask what STI causes a painful lesion, almost everyone will first tell you Haemophilus ducreyi, and it causes a chancroid, and it's painful, right? It's a painful genital ulcer with exudate, and you'll also have inguinal adenopathy. Chlamydia just causes urethritis, cervicitis, epididymitis, conjunctivitis, as we just talked about it, reactive arthritis, and pelvic inflammatory disease. But it's not necessarily going to cause any painful lesions. Condyloma acuminata is something that's caused by your HPV, right, papillomavirus, right, genital warts and coilocytes. Genital herpes from HSV2 will cause painful penile vulvar or cervical vesicles and ulcers. Right, so Haemophilus ducreyi was painful, HSV2 is painful. Right, you also have other symptoms from HSV2 such as systemic symptoms, fever, headache, myalgia. Gonorrhea, also not painful. Right, so chlamydia is not painful, gonorrhea is not painful either. Same issue as chlamydia, urethritis, cervicitis, PID. There's also the prostatitis, right, and the creamy, thicker discharge than the chlamydia one. The last one here, granuloma inguinale, right? Granuloma inguinale. This is going to be from Klebsiella, right? Klebsiella, or it can be Donovan bodies that you're also seeing from Donovanosis. So what is this? This is painless as well. Beefy red ulcer that bleeds readily on contact, right? And they're showing you an image of that. Very uncommon in USA. Very uncommon in USA. You're probably going to get this as a question of someone that just came to the US, right? They brought the infection with them. Hepatitis B can also be sexually transmitted, right? So that's what I was telling you earlier when we were looking at the hepatitis 2 days ago, that hepatitis B is usually going to be a question about a man or woman who have multiple sexual partners and they might not be using protection all the time. Whereas hepatitis C is going to be related to a patient who does IV drugs. Lymphogranuloma venereum was related to chlamydia trachomatis. Right, this was painless genital ulcers, painful lymphadenopathy like buboes. Treponema pallidum. Now, treponema pallidum has 3 different levels, right? Primary, secondary, and tertiary. All 3 levels are painless. There's no pain, right? When we were up here, chancroid from Haemophilus ducreyi is painful, right? And then your genital herpes is painful, but not anything in syphilis, right? Not anything in syphilis, and obviously not trichomoniasis either. Trichomonas vaginalis doesn't cause any pain either. Now, in syphilis, there's something called condyloma lata, right? Do not confuse condyloma lata with the condyloma acuminata of HPV. Very important to not make that mistake, right? HPV is the acuminata. There's a lot of different forms of syphilis, so you can remember that for condyloma lata. There's a lot of different forms of syphilis, primary, secondary, or tertiary. So that's pretty significant there as well. So only 2 real painful guys, right? Ducreyi and HSV2. Pelvic inflammatory disease, right? So this is what happens to patients who either chronically keep getting chlamydia or gonorrhea or don't really treat it well the first time they get it. Right, so the top bug that causes PID is chlamydia trachomatis. Subacute, often undiagnosed, and then Neisseria gonorrhea, which is acute. Right, so a patient who might have had Neisseria gonorrhea infection and only treated the gonorrhea but didn't also treat the chlamydia might later on end up having subacute PID. Chlamydia trachomatis, most common bacterial STI in the US. Signs include cervical motion tenderness, adnexal tenderness, and a purulent cervical discharge. PID may include salpingitis, endometritis, hydrosalpinx, and tubo-ovarian abscess. Salpingitis is a risk factor for ectopic pregnancy, and that's what pelvic inflammatory disease is an issue for. Right? A patient who might have had pelvic inflammatory disease can later on also just develop ectopic pregnancy, and that's going to be really bad. If it's not an ectopic pregnancy, then something else can get damaged, and they'll just become infertile. That's another issue. Right, can lead to perihepatitis. Perihepatitis. That's your Fish-Hugh-Curtis syndrome. Right, infection and inflammation of the liver capsule and violin string adhesions of the peritoneum to the liver, and that's what they're showing you here. Right, amazing how they were able to get that picture too. That's a Fish-Hugh-Curtis syndrome, and that was in your Neisseria gonorrhea image as well. They talk about it there. Nosocomial infections. There's a bunch. E. coli and S. aureus are the 2 most common causes, but really speaking, it's going to be most bacteria who you cannot treat well, right? Bacteria that are very resistant to all the antibiotics a patient might be taking, especially a hospitalized patient. That's why it's nosocomial. So a patient that just recently took antibiotics can develop C. difficile diarrhea, right? And they'll have watery diarrhea. That's like the most common thing that always keeps happening. People who have aspiration, either due to altered mental status or old age, which encompasses being alcoholic, it also encompasses someone who had a stroke and their pharyngeal muscles are weak. Aspiration can lead to polymicrobial pneumonia. Right? It can be pneumonia from any bug that's normal in the oral flora. We talked about that earlier when we looked at pneumonia. Decubitus ulcers, surgical wound drains. These guys are going to be at risk of S. aureus, including MRSA. Decubitus ulcers in people with surgical wounds or any surgical draining that's happening, these guys are going to be at risk of S. aureus, including MRSA. MRSA is more likely going to be the answer because S. aureus you could treat, but methicillin-resistant one is harder to treat. And one of these other guys that are gram-negative anaerobes, right? Bacteroides, Prevotella, Fusobacterium. And you're going to see just general things that you get from inflammation. Erythema, tenderness, drainage from the surgical wound site. Right? And you'll know what happened when you see the question. Patients who have intravascular catheters that are not being regularly changed, right? There's a protocol to changing catheters very regularly. You don't leave the catheter there, and you definitely stop using the catheter once no longer necessary. But if intravascular catheters are left, then S. aureus, S. epidermidis, and Enterobacter are the main guys that can possibly cause an infection. Patients on mechanical ventilation or endotracheal intubation are at risk of Pseudomonas aeruginosa, that's usually the answer, or Klebsiella, Acinetobacter, and S. aureus. Usually going to be Pseudomonas aeruginosa though. What you're going to know is ventilation-induced pneumonia basically, and you're going to have a new infiltrate on chest x-ray, right? Sweet odor will be the giveaway for Pseudomonas, or even description of anything else related to Pseudomonas is a pretty good giveaway. Renal dialysis unit and needle stick, again, hepatitis B, hepatitis C. Usually for the needle stick stuff, hepatitis C. Urinary catheterization, right? So we just talked about intravascular catheters. Urinary catheters also need to be regularly changed and no longer used if not necessary. So if a urinary catheter is not removed, you want to start thinking of Proteus mirabilis, right? That's like the main cause of UTIs in hospitalized patients, or E. coli or Klebsiella. I mean, so many guys cause UTIs. The question has to do a pretty decent job explaining to you enough things for you to be able to do the differential and knock out other answer choices. The last one here that can cause nosocomial infections are your water aerosol-induced Legionella. Right, so you're going to get this atypical pneumonia in a patient who came to the hospital without pneumonia. Right, patient came to the hospital because of something else. They were hospitalized maybe for 2 to 3 days, and now a little later they have Legionella pneumonia, atypical pneumonia. Boom, it's Legionella because of water aerosols. They must have just been really weak, and boom, they have pneumonia because of Legionella. So it can just happen. Remember, Legionella causes neurologic symptoms and diarrhea on top of the pneumonia. There was that salt wasting. Bugs affecting unvaccinated children basically encompasses children that are coming with parents from another country, right? Unvaccinated children. So if they have a rash, unvaccinated children, if they have a rash, you're down to just rubella and measles, right? And then you have to start thinking of how the rash looks. If the rash is very, very, very condensed, right, very condensed. Remember, we just talked about it from up here. Let me see. Right, so rubella, measles. If the rash is very condensed, right, confluent rash, it's measles. Otherwise, rubella has very discrete, further apart rashes, right? And that's really the only way to differentiate between the two. There really isn't anything else that's very different. Now, of course, for measles, you can look for these other things if the child has it. Right, Koplik spots definitely a giveaway for measles. But if the baby doesn't have, or the child doesn't have any of these other symptoms, and they have a rash that's being described and post-auricular lymphadenopathy, then you just go with rubella. Don't think about it too much. Unvaccinated and you got meningitis in this kid, well, it's going to be H. influenzae type B, or it could be your enteric, what was this guy? Picornavirus, the poliovirus, right? So depending on which one it is, they'll have those symptoms. H. influenzae causes epiglottitis, which is pretty unique to H. influenzae. So that's, a good way to pick that out. Poliovirus causes many other issues, especially the polio of having smaller limbs. So you got to watch out for that. If they haven't gotten vaccinated, then you want to tell the mother what's coming. Tetanus is another one. right? Muscle spasms and spastic paralysis, lockjaw, upper nose, and many other things because of Clostridium tetani in a child that was never vaccinated for tetanus. So you have to go ahead and give him the whole thing, the vaccination as well as the treatment and everything you can do supportively, right, for any baby. And if the baby does have tetanus, then the baby's history will tell you what's up, right? Maybe they have some kind of cut or some kind of stab somewhere from some kind of metallic thing by mistake. In respiratory, epiglottitis is always going to be a giveaway for H. influenzae. It's really the only guy that causes it. So you have a trade red epiglottis and a thumbprint sign on an X-ray, right? Capable of causing also capable of causing epiglottitis in fully immunized children. So anytime you see epiglottitis, even if the child was immunized for H. influenzae, it's still H. influenzae. No one else causes epiglottitis as far as you're concerned for STEP. Pertussis is from Bordetella pertussis, right, with the 100-day whooping cough, right? So low-grade fevers, cries, whooping cough, gradual recovery. It's just 100 days cough. It's going to take a very long time, but they'll eventually get okay. Pharyngitis, Corine bacterium diphtheria. It's not just pharyngitis. You're going to have that pseudomembrane. You're going to have many other issues if untreated. It also causes cardiac issues. So you want to treat it. You want to treat it as soon as possible. This last thing here is just a list of bugs. Right now, we talked about all kinds of different carriers for infections, whether it be a mosquito, some kind of tick, or if it's just there in a dog or a cat, anything. You do need to remember it. You do need to remember it because little details like that are going to be giveaways for the bug, and it'll really help you differentiate between one bug over the other. All right. This question here is for Burkholderia serpatia. The reason I put it here is just because it was the only question I ever found for Burkholderia. A 7-year-old boy with a history of recurrent granulomatous skin infections and a prior episode of Aspergillus pneumonia undergoes a partial hepatectomy to treat a poorly draining liver abscess. Genetic analysis reveals an inactivating mutation affecting a structural component of a neutrophil oxidase enzyme. He most likely has increased vulnerability to infections by what pathogen? And of the answer choices, Burkholderia was the only one that would cause an issue in some child with chronic granulomatous disease. That's what he has. That's why he's been getting these prior episodes of Aspergillus, right? He has the genetic analysis of neutrophil oxidase not working, which is pretty much diagnostic of CGD. And all the microbes that can cause infection in CGD are generally these guys right here, right? Catalase positive. Any bug that you can remember seeing a cat in the sketchy micro picture is catalase positive. It's going to infect CGD patients. The rest of them are just for you to look at and memorize on your own free time, but you'll remember them as you see them. When you studied each one of these bugs, you already saw what characteristic was necessary to get that infection. All right. So each one of these bugs have a different characteristic that's pretty unique to it, and helps you pick that bug as an answer over other bugs, right? So you would pick Asarius if you're seeing pus and paima and abscess and nothing else to point out another answer choice. Okay, so that finishes up systems. In the next video, I'll go into antimicrobials, which is a pretty dense chapter in itself and a very high yield chapter. A lot of this keeps coming up over and over in step 1 as well as in NBMEs. So we'll look at this tomorrow, and yeah, that's it for now. I'll catch you guys later on.